Go ahead.
Am I audible, sir?
Yeah, you're audible.
Okay. Sir, my topic is COPD patient coming for lab cholecystectomy.
Hmm.
Uh, it's a Madhu, 65-year-old male patient from Chennai, admitted before 1 week with complaints of difficulty in breathing for past 2 weeks, uh, and cough with expectation for past 1 week, and now abdominal pain on and off for past 1 week, and now admitted and found out to have multiple gallstone, lab cholecystitis. History of wrestling illness, history of difficulty in breathing for past 2 weeks. Initially was only associated with exertion. Now for past 2 days, the breathlessness has increased. For past 2 weeks, the aggravation factor was coughing. Coughing aggravated the breathlessness. No history of diurnal or postural variation. No history of PND or orthopnea. No history of chest pain or swelling of legs or decreased output. No history of fever. No history of loss of appetite or weight. No history of night sweat. No history of pain swallowing. No history of hoarseness of voice or puffiness of face. No history of abdominal distension. No history of right hypochondrial pain. History of cough with expectoration for past 1 week. Incidence in onset, productive in nature. History of no history of postural or diurnal variation. Initially 2 to 3 episodes per day. Now it is more than 10 episodes per day. Sputum is mucoid, white to yellow in color, around 5 ml per episode. No history of foul smelling or staining of blood. Past history, history of similar complaints in the past present, admitted around 3 times for past 3 years for the same complaint, diagnosed to have COPD, was on inhaler, now stopped before 3 weeks before admission. No history of diabetic mellitus, systemic hypertension or CAD or seizure disorder or pulmonary TB. Family history, no relevant family history. Personal history, patient is a non-smoker, smoked 90 pack years. He smoked 40 cigarettes per day for 40 cigarettes per day, 2 packets per day for past 45 years. Mixer diet, normal bowel and bladder habits. Treatment history, he was on bronchodilator, is a defaulter, was admitted in MICU for breathlessness previously, was on NIV support, IV steroids and nebulization and recovered. No other significant histories. Summary, a 65-year-old male patient with complaint of breathing difficulty for past 2 weeks and cough with expectation for past 1 week with similar episode in the past and was on bronchodilator therapy. I would like to evaluate further. Now with complaint of abdominal pain coming for lap cholecystectomy. General examination, height is 163 centimeter, weight is 76 kg. Patient in sitting posture, not dyspneic or tachypneic. No pallor, icterus or cyanosis. No generalized lymphadenopathy, clubbing or pedal edema. No elevated JVP or abdominal distension. BP, left upper limb in sitting posture, 110 to 110 bar 170 mm Hg. Pulse rate is 90 per minute. Regular rhythm, normal volume, no radioradial or radiofemoral delay. And felt all peripheral pulses felt, no vessel was thickening. Airway examination, external airway appears normal, no deviated nasal septum, mouth opening is more than 3 finger breaths, mallapetic class 2, range of movements normal, short neck, fine faces felt. Systemic examination, RS inspection, respiratory system inspection, trachea appears to be in midline, chest wall bilaterally symmetrical, no chest wall deformity, moves equally with respiration, no obvious kyphoscoliosis, no scars or engorged veins. Palpation, trachea position confirmed, chest wall moves equally with respiration, apical impulse felt in the left medial to mid-clavicular line in the fifth intercostal space, chest expansion, inspiration to 95 cm, expiration to 86 cm. Anteroposterior diameter is 18 cm, transverse diameter is 26 cm, no intercostal tenderness, vocal fremitus is normal. Percussion, normal resonance in all areas, no tenderness. Auscultation, bilateral normal vesicular breath sounds heard on all areas, mild inspiratory crackles present in the interscapular and subscapular area. Central cardiovascular system, S1 S2 heard, no murmur. Central nervous system, higher mental function is normal, reflexes normal, motor and sensory function normal, cranial nerves normal, no focal neurological deficit. Provisional diagnosis, a 60-year-old male patient with complaint of dyspnea and cough with expectoration, known case of COPD and bronchodilator defaulter, Probably a case of acute exacerbation of COPD without any symptoms of cor pulmonale. Now with multiple gallstones posted for lap cholecystectomy. Yes, sir.
So, what is the significance of that admission 3 times in the last 3 years in the hospital?
Frequent exacerbation of COPD is present for the patient. So respiratory failure chances are more.
Respiratory failure. Now, what are the components or what are the types of COPD? What is the two types that you get into?
COPD is progressive airflow limitation that is not fully reversible, consists of chronic bronchitis and emphysema. Chronic bronchitis is a cough, obstructed small airway, cough persisting for more than 3 months or more than 2 episodes in successive years. So he is having a feature of chronic bronchitis predominantly.
So that the history itself suggestive of chronic bronchitis. Correct?
Bronchitis.
Isn't it?
Yes.
So how do you expect the patient's physical appearance to be in chronic bronchitis?
Yes, sir. Chronic bronchitis, blue blotters, sir.
Blue blotters. So he will be
Yes.
bulky, he may be
Yes.
cyanous, he may be dyspneic also.
Dyspneic. Yes. Yes.
Which is more serious, chronic bronchitis or emphysema? Which has
In
got a good prognosis?
good prognosis, emphysema.
Emphysema and a better prognosis compared to
Than
chronic
chronic
bronchitis.
bronchitis.
So anatomically, what are all the structures of the respiratory tract which will be affected if you brand a patient as COPD, that is chronic obstructive airway disease patient? If you brand a patient like that, anatomically, which are all the structures in the respiratory tract which will be affected?
Respiratory bronchioles and alveolar destruction is common in emphysema, and small airway obstruction, irreversible small airway obstruction is seen in bronchitis.
What about the vasculature, pulmonary vasculature? Does it belong to the respiratory system or not?
Yes, sir. Increase with this vasculature is increased in
Vasculature increased or undergoes modification?
peripheral vascular.
Why do you say talk about carpulmonale?
That increased RV, the pulmonary vascular constriction will be there, so increases
pulmonary hypertension. Right. They develop pulmonary hypertension, which leads on to right ventricular
hypertrophy and carpulmonale. Peripheral edema, hepatic congestion,
etc. Structures which are affected by COPD. Airways larger than 2 millimeter size with a cartilage. Airways lesser than 2 millimeter without a cartilage. Alveolar sacs, and then pulmonary vasculature. All the four are affected, producing. And what is the pathology that happens in larger airways more than 2 millimeter? What type of reaction happens in that airway?
Inflammatory response, elastic, increased elastase activity and decreased alpha-1 antitrypsin activity, so result in the degradation of the product.
What about the lining epithelium? What type of epithelium is lining the tract there? Does it have secretory glands?
It's a mucus secretory.
So they are also irritated and they produce a lot of mucus secretions. That is the reason for the cough they have consistently. They want to clear those secretions. Yes. And the lower airway, the smaller than 2 millimeters, they are the ones which are going to be narrowing on and off, producing obstruction. And the alveoli which are destroyed, they go in for what is the problem will happen if alveolar are destroyed?
Emphysematous, so it won't be fully, during expiration, it won't be fully collapsed. So air trapping will be there. Okay. Elastic property will be lost.
Okay. So these are the four things, the pathology that happens in this patient. Now, this patient, supposing I give you an option to do some investigation, which are
Yes,
all
sir.
the tests or investigation? Supposing there's a very short time, patient is admitted, he is in acute pain, surgeon is insisting that he may rupture the gallbladder because there is also some cholecystectomy reaction because of the stone, and he wants to operate as quickly as possible. So
Yes,
there
sir.
is a lot of adequate time. What are all the investigations you would like to do in this case?
That's the complete blood count I like takes to know about the hemoglobin status because polycythemia may be common in this patient. And to see about the infection status, leukocytosis may be there. So total blood count. Mm.
Okay.
Then uh, then I ask for a chest X-ray, sir, that's a chest X-ray, which will reveal the lung condition of that hyperlucency, tubular heart, or any
Oh, this
features of
case
COPD.
already from the history, it looks like only a chronic bronchitis case. Why do you want to
Yes,
see
sir.
whether there is
Then
lymphatic?
ECG I can order an ECG, sir,
Hmm.
so that to see any RV strain pattern or right ventricular hypertrophy is there.
Okay.
So any features for P
How do you
pulmonary
assess the
to indicate
severity of this COPD?
pulmonary function test is.
All pulmonary function tests you want to do, or you want to
We can ask about some bedside pulmonary test we can do if it is an emergency. Sub
bedside pulmonary function test to assess the severity, use
severe, not
criteria, and
severe.
gold
FEV1 by
criteria, gold
FVC
index,
ratio.
all these things. What do they need?
FEV1 by FVC ratio is the
Ah.
criteria to assess the severity, sir.
So the most important pulmonary function you want is to assess the FEV1 and FEC.
FVC. Yes,
Okay.
sir.
Anything else which is included in the pulmonary function test other than this spirometric test? It will tell about the respiratory functional status, oxygenation and carbon dioxide elimination.
DLC.
Told you there is very short time. How do you assess the respiratory function? Whether the oxygenation is normal and carbon dioxide elimination?
ABG. ABG.
ABG, yeah. That is the easiest, isn't it?
Yes,
So,
yes,
if this sort of question is asked within a given time or a short time, if you want to assess the severity, you need to know the FEV1, FEC,
yes,
then assess the ratio and use either the board index or the gold criteria to assess the severity, whether it is mild, moderate, severe, very severe, and do an ABG to find out the oxygenation and CO2 elimination.
yes.
What sort of result do you expect in a patient with this sort of picture? Any idea?
Chronic bronchitis, PaCO2 will be elevated.
Hmm.
And PO2 will be reduced, marked decrease in
What
chronic
is the pH
bronchitis.
like? What is the importance of pH in this ABV result?
That compensatory, usually COPD patient will, even though with the higher PaCO2, pH will be in normal range because of the compensation.
Very good.
Because if it is an acute exacerbation in respiratory failure, the pH will be reduced along with increased PaCO2.
Very good. What other important parameter you have to look for in the ABG to find out whether there is whether the condition is compensated or uncompensated?
Bicarbonate level will tell bicarbonate.
Very good. So supposing
Like
bicarbonate is very low, instead of increasing to compensate for the uh, persistent hypercarbia, what does that mean?
yes, it is ongoing increase in that is trying to compensate, but it's not compensating. So the patient is going into respiratory
Instead of
failure.
being 20, 27 or 30, the
Yes,
bicarb is also only 15 or 16.
yes, sir.
Then what does it indicate? Is there any added
Sir,
metabolic problem?
is
Ah,
combined defect, combined
ah,
metabolic acidosis with respiratory.
so don't forget to look at the bicarb value. In a well compensated state, even with hypercarbia, pH should be normal and bicarb should be elevated. That is the normal
Okay,
compensation that body will do. On the contrary, if the bicarb is low with a normal pH, that means there is a added metabolic
Acid.
acidosis also in that patient, which we have to be very, very careful about, right?
Okay. Okay.
Supposing the surgeon gives you 1 day time to prepare the patient, how will you prepare the patient?
First, we can start him on oxygen therapy, but not if the patient is having any dyspnea or any respiratory symptom, we can put him on CPAP or non-invasive ventilation. If it indicated any associated respiratory rate or tachycardia is there, we can start on that. Then if the patient is still smoking, you can ask the patient to stop cessation of smoking. Then start on IV antibiotics.
You should say. Okay, always.
Yes,
Because the questions clearly says he smokes 2 packs per day
yes,
for 45 years. So how
yes.
many pack years?
90 packets.
90 pack years. So it is a multiplication of number of packs per day multiplied by the number of years of smoking is the pack years. So 90 pack years of smoker, he cannot easily quit smoking. So the first and foremost advice in the exam you have to say is, I will ask the patient to
Smoking
stop
cessation.
smoking if he is still
Smoking.
smoking. Because patients who are addicted to smoking will quietly go into the washroom and have 1 or 2
Yes.
puffs and come back. Okay, so that is the first advice. Then you start about the oxygen therapy, bronchodilator,
Optimization.
chest
Yes.
physiotherapy, incentive spirometry, all those things you have to stay in order. And then,
Okay.
supposing he has a lot of productive cough, what is the minimal amount of sputum that you would like to have in this patient?
Now he's having a sputum. So
Supposing he has a lot of sputum coming and we measure it and
yes,
it
sir.
is about 100 ml. Would
Yes.
you be happy with that?
No, sir.
So what is the amount that you can accept for 24 hours? What is the minimum amount that you will accept or the maximum amount you will accept? It should be less than 30 ml per 24 hours.
30.
Okay?
Okay.
So
Okay.
30 ml should be the ideal. Less than that is
Okay.
also good. Right. So all these things are there. ABG shows mild hypercarbia. PCO2 is 55, PO2, PaO2 is 84, pH is 7.38, bicarb is 27. So he is in a compensated state. He is
Yes.
posted for lab chole. And lungs are
Yes.
fairly clear after your 1 day physiotherapy and cessation of smoking. Another question they can commonly ask you is how soon after stopping the smoking the respiratory system comes back to normal.
So depending on the time of the cessation, from 12 to 24 hours, the carbon monoxide level in the blood will become normalized. Sir.
Six
Then
hours,
PO2 will.
6 hours is enough
Uh,
to reduce the carbon monoxide, not 24
yes.
hours. So 6 hours is
6.
enough to reduce the carbon monoxide. And 24
Carbon
hours
hemoglobin will come.
reduces the ciliary hyperactivity. I mean,
Yes.
the respiratory irritability. Okay. Right. So,
And 48,
48 hours.
48 to 72 hours, ciliary function will improve.
Mm. But if you
And
want a
2 weeks,
complete restoration of the normal function, how long you need to stop smoking?
uh, equal to more than 6 months before surgery, it's non-smoker. But up to 6 weeks, even immune function will return. So
Right. So these are the common questions we have to expect with regard to smoking. And what are all the other bad effects of smoking? That may be another question that is commonly asked. So apart from the respiratory system effects, does smoking have any other effect? The
it's
cardiovascular system?
nicotine will cardiostimulatory and CNS stimulatory effect of nicotine.
Hmm.
So tachycardia, arrhythmias may be
What is
precipitated
the
with
one
nicotine.
advantage of smoking? I mean, when a patient
POS will be post-operative nausea vomiting will be
nausea,
reduced.
vomiting will be less. That is the only advantage of smoking. All of this are bad. Right. So patient has stopped smoking. You have prepared the patient with all the usual preparations of test CO and the taken bronchodilator, everything. Patient looks better now. He's posted for lab cholecystectomy. Tell me how you will manage this thing, all the steps, practical management of this.
Yes. After optimizing the lung condition, so we'll pre-medication has to be given. First, you have to explain the patient about his condition and risk factors associated with. So to get an informed consent of the patient. So if it is an emergency, so additional consent for post-operative ventilation and high-risk consent has to be obtained from the patient. So since there is a chance of post-operative ventilation, so separate consent for ventilation. So separate consent to be obtained regarding that, and patient has to be explained about the procedure. Then pre-medication has to be given for the patient, including continuing the bronchodilator therapy, antibiotics, and steroid therapy for the patient. Then glycopyrrolate can be given.
Okay, based on the one second, based on the preoperative treatment patient has taken for this COPD, can you assess the severity of the COPD?
Post bronchodilator therapy, if the respiratory function, the obstruction is not improving.
No. Please understand my question. Supposing you ask for the treatment modality patient has been taking all these years for the COPD, based on the treatment schedule, can you assess the severity of the COPD or not?
Yes, sir. If the group A to D, usually the drugs involved will be there. Group A is with few symptoms and lower risk of exacerbation, only long or short-acting bronchodilators will be taken by the patient. In group B, it's the bronchodilator, 2 bronchodilators will be taken by the patient. Group C, if it is more than that, so a muscarinic agent with bronchodilator therapy will be there for the patient. So combination of drugs in group T, in inhaled steroid and or systemic steroid with the bronchodilators and muscarinic therapy will be there for the patient. So depending on the number of drugs patient is taking, severity can be assessed.
Yeah, so that is a very important treatment history you have to elicit in the pre-operative assessment to assess the severity. Okay. Right. Okay, go ahead now. So you have informed the consent has been obtained. All the risks explained. In the, if necessary, need for post-op elective ventilation also has been explained to the patient, right?
Yes, sir.
Then only an elective procedure. This lap cholecystectomy is not an emergency procedure. It is done as an elective procedure.
Yes, sir. So, in view of COPD, minimally invasive procedures is preferred. So, lap chole will be preferred over open. So, preparation of OT should be done with emergency drugs, all the necessary equipment.
What about the immediate pre-op preparation of the patient, like starvation guidelines, any pre-operative?
NPO, yes, sir. NPO has to be followed by the patient. So, 8 hours NPO with anti-aspiration prophylaxis of Pantox can be given for the patient with the continuation of the bronchodilator therapy and IV steroids 1 hour prior to surgery. A dose of steroid can be given for the patient. Then patient shifted to the OT.
If on repeating steroids, there is likely to be one question commonly asked in the exam. What are the steroids that are used for treating this condition?
So inhaled steroids like fluticasone and budesonide are used for COPD inhalers.
Okay.
Then in acute exacerbation, you can use cortisone. Stat dose can be given, and along with the dexamethasone can be added and tapered in stopped in tapered doses for the patients.
Any role for methylprednisolone in
severe acute exacerbation with not subsiding with hydrocortisone or for immediate relief we can use methylprednisolone also with aminophylline.
Equal doses or equate doses of comparison between methylprednisolone, dexamethasone, hydrocortisone. Do you know how?
I just forgot. So once I read 100 mg No, I forgot.
That is another question they may ask you. What are the
Right.
equipotent values of methylprednisolone, dexamethasone, and hydrocortisone? It is
Yes.
also a common question that may be asked in the examination. You have to know the answer. Okay, right.
Okay, sir. I'll read.
Right. So this is the immediate pre-op preparation. Patient has now
Yes.
come to the OP. Tell me the
Yes.
steps in the management of this patient.
First, patient should be positioned in the table with the monitors attached, NIBP, ECG, pulse oximetry, and should be attached to the patient. Pre-medication to be given, and pre-oxygenation for more than 5 minutes has to be given for the patient with 100% O2. Then we can induce with the propofol. Propofol, the patient's hemodynamics, this patient is stable, so we can induce with propofol. In greater doses can be given. And since the airway, after assessing the airway, if it is okay, you can induce muscle relaxant can be given as succinylcholine, or preferably atracurium is avoided since it causes histamine release and chance of bronchospasm is there. So cisatracurium or vecuronium can be the muscle relaxant of choice. With intubated using 8 or 8.5 tube after adequate relaxation is obtained. Then ventilatory parameters has to be set for this patient. One is IE ratio should be normal, lung protective strategies to be followed. The IE ratio should be, expiration should be more. Since it is a COPD patient, there is air trapping. So IE ratio should be kept as 1:3, preferably 1:2.5 or 1:3. And slow breathing rate, that is 12 to 14 breaths, so that there is during expiration there is a chance of complete emptying of the alveoli. So slow breath rate with increased IE ratio and lesser PEEP. PEEP is usually avoided since it is COPD. And to target should be maintained to keep the peak inspiratory pressure less than 40. Then tidal volume to be kept as 6 to 8 ml per kg and with slow inspiratory flow rates. Then connect to the
As soon as you
ventilator.
have intubated the patient, the bag is very tight before you connect him to the ventilator.
Yes, sir.
What are the reasons for that?
One is acute bronchospasm can be there for the patient. Sir. So after auscultation,
Think it is only bronchospasm?
the pardon, sir, is not audible, sir.
So, is the bronchospasm the commonest cause for tight bag, or other reasons are there?
A rupture of bulle or
So you have to first define whether it is the patient defect or the machine defect.
bag
That is
defect.
the exam answer should be given. Okay.
Okay. Okay.
It may be a fault in the machine also. Always
Okay.
it is not fault with the patient. Okay.
Okay.
So what are the machine causes and what are all the patient causes? That is how you have to classify.
Okay, so one will be the stuck valve can be a reason for the back tightness.
Anything else?
Then block in the expiratory limb, block in the tube can be there.
There are so many 3-4 reasons given for machine faults. One is the oxygen flush may be silently working. We have used that.
Okay.
A partially stuck, or the valve, expiratory valve might have been stuck, or there may be a kink in the tube, or maybe a connection which is blocked.
Defect.
Sometimes the elbow mount that you use may be having something foreign body inside. Okay?
Block.
So all these things have the machine causes. So how to differentiate whether it is a machine fault or a patient fault?
First, you have to check all the connections of the patient and to see any. Then, if it is a Okay, then I have to check the then auscultate the patient for any test signs.
Correct. What is the correct answer for this? How to differentiate between a machine fault and the patient fault? Sheshwar Rao or Pratik Shukla? Can anyone help Ammu? Always disconnect the patient from the anesthetic circuit, attach an ambu bag, okay, and try to
Okay.
ventilate the patient. If you are able to keep the bag well, chest expansion and air entry is normal with the ambu bag, that means patient is normal. The machine is only at fault. Okay. And the contrary, even with the ambu bag, if you are not able to ventilate, that means it is a bronchospasm or pneumothorax or endobronchial intubation, any of the reasons which the patient may have. Okay. So that is the answer that you have to give. You have to disconnect the circuit, attach an ambu bag and try to ventilate the patient. If normal ventilation is possible, it is the fault in the machine. So check for all the fault or change the machine and try to continue with the ventilation. Especially with the workstations with so many faults that can suddenly happen, even in spite of the regular checklist that is being followed, suddenly something may go wrong. So this is the best way to detect any problem with the machine or with the patient. Okay.
Okay.
Right. Go ahead. So what
Then
are the changes that happen, pathophysiological changes that happen because of lap surgery?
one is because of pneumoperitoneum. One first is pneumoperitoneum. Next is because of the steep Trendelenburg position they are using. Pneumoperitoneum will cause.
Do they produce steep Trendelenburg? You have to talk
No, sir.
relevant to the case that you are discussing.
It's the opposite, no? It's a head up.
Yes, head up and left, right tilt, ma'am. For laparoscopic surgeries are commonly told, ma'am. For this lap cholecystectomy because of the pneumoperitoneum major effects.
So what are all the cardiovascular and respiratory changes and any other system can be affected by laparoscopic surgery created by creating the pneumoperitoneum?
Yes, one is cardiovascular. After creating the pneumoperitoneum, can be sympathetic response or parasympathetic response. If the sympathetic response is elicited, it can cause because of the sympathetic stimulation can cause tachycardia, hypertension, and increase in ETCO2. If the parasympathetic response is elicited, patient can have bradycardia or hypotension initially. Then sympathetic response will be elicited.
Is it how described for the cardiovascular changes in the pneumoperitoneum? Is it described like this, sympathetic and parasympathetic, or it is described as biphasic, phase 1 and phase 2?
Phase 1 and phase 2, sir. Initial parasympathetic and followed by sympathetic
No.
stimulation.
It is mainly because of the increase in the intra-abdominal pressure. You are insufflating carbon dioxide and you are raising the intra-abdominal pressure. So what this pressure will do on the vasculature, intra-abdominal vasculature?
In the IVC compression will be there. Yes, sir. IVC compression and causes a decrease in venous return.
First thing, will it be immediate decrease in venous return? See, when you compress, what will happen? All the blood that is in the IVC, where will it go? Will it go towards the heart or will it go towards the leg?
Towards the periphery.
Huh?
Towards the periphery.
Periphery. So veins will go in the backward flow also, is it? They are coming from the leg. Distally, they are coming from the lower limb.
Yes, sir.
Going through the IVC, going to the heart. So if you apply compression, will it be a forward flow towards the heart or it will be a retrograde flow towards the legs?
Forward flow towards the heart.
There are valves, to prevent the backward flow.
Yes, backward flow.
So it goes only towards the heart. So the first effect is the compression of the blood of the IVC squeezes all the blood from the IVC towards the right atrium. So there is an increase in cardiac return. Isn't it?
Yes.
And this cardiac return has to get pumped out. So there is an increase in cardiac output initially. But because the pressure is sustained, continuous, after it has pushed out the blood, it is preventing further blood coming from the lower limb into the IV. Okay,
Yes.
that is the
Yes,
time when the venous return will decrease. This is why it is called a biphasic response. First phase is
okay.
increased venous return because of the squeezing of the IVC. By second phase is decreased venous return because of the blocking effect on the IVC. Okay? So for
Okay.
that
Okay.
second phase only, when there is a venous return decrease, heart has to increase its heart rate to maintain the cardiac output. So it goes into
Okay.
tachycardia.
Tachycardia.
And that also pressure also goes up because there is a systemic vascular resistance is also increased because of this
Increase.
IAP. Okay,
Yes.
so that is how the whole thing manages. So increase in blood pressure, cardiac output happens initially, but the decreased venous return tries to decrease the cardiac output, which is compensated by tachycardia and increase in SVR. These are all the changes that happen in the. So in a patient who has any compromised coronary circulation, this will be very deleterious. These changes
Yes.
taken on
MI.
instant. Okay, so that is the thing that we have to clearly understand. What about the respiratory changes because of the pneumoperitoneum?
Pneumoperitoneum, the diaphragm may be pushed upward by the abdominal content. So basal atelectasis and decreased FRC can be there for the patient. So there can be chance of desaturation for the patient.
Okay.
And
What
the
about the
tube
renal
can
system?
renal
system affected?
Yes, the renal vasoconstriction may be there because of splanchnic and renal vasoconstriction. GFR may be reduced and renal blood flow may be reduced and GFR may be reduced and urine output may reduce for the patient.
So these are the three important changes that you have to remember. And what about the carbon dioxide absorption?
So intracranial pressure, sir. So intracranial pressure in.
Renal pressure, yes, sir. Yes, ma'am. Because of the pressure, the intra-abdominal pressure, Braxton venous plexus pressure also will increase and can cause raised in ICP, and the IOP may be raised for the patient.
So these are all the added disadvantages. Supposing the CO2 absorption is, what is the pattern of CO2 absorption that will happen when you create a new peritoneum AC carbon dioxide? Will the rise will be going on happening, or will it, what, supposing you are asked to plot a graph of CO2 absorption into the blood, how will you draw that graph?
It's initially a steep peak followed by a plateau. That initial steep peak, because of the pressure and the high flow rate, the PCO2 will go on increasing and reaches a plateau of plateau.
Plateau maintains till this CO2 release is done, isn't it? Initially, there's a rapid rise. After that, it stabilizes at a particular level and the plateau is maintained. Supposing after about 30-40 minutes of plateau state, there is a sudden increase in CO2. What does it indicate? Is there any significance for that?
This vascular absorption may be a chance.
Vascular absorption already has taken up. No, that is the reason why the level goes up.
Carbothorax can.
An extraversation. The mediastinal
carbothorax.
So there is a rupture. There is a leakage somewhere. Okay, so that is the indicator. So probably after a plateau of 30 to 45 minutes, if there is a sudden increase, you have to suspect the extravasation of CO2 into the tissues, especially mediastinal emphysema. Okay? The surgical emphysema also may be sometimes happening. That is the one important indicator of the sudden rise in CO2 after a plateau state. Right. So, what are the effects of CO2 absorption? How do you nullify that? How do you manage that CO2 increase in a patient with
initial increase in CO2, that is 30 to 40 is cardiostimulant. and CNS stimulant for the patient will have tachycardia and increased blood flow. But if CO2 is increased more than 60, it is direct cardio and CNS depressant. And so to prevent that, and it is initially it will cause respiratory stimulation also. Patient will have increased respiratory drive. But after a point of 60 to 70 mmHg of CO2, patient will have all the cardiovascular and respiratory and CNS depressant effects. To avoid that, you can decrease the tidal volume and increase the respiratory rate. It will wash out the CO2. Then can ask the surgeon to decrease the flow rate of the gas and to decrease the abdominal pressure.
So in these patients, very important to make sure that the intra-abdominal pressure never exceeds more than 12 millimeters of mercury.
12.
So that is the safe limit beyond which it may start having hazardous effect on the absorption of CO2 also.
Okay.
So what about extubation? Surgery is completed successfully. How do you plan for extubation of this patient? What are the criteria you have to follow during recovery?
If the patient's preoperative condition like PCO2 is within normal range and patient is conscious oriented, and after if it is severe COPD, we can take an ABG post surgery. And if the PCO2 and bicarbonate level and pH is within normal limit and PO2 is within normal limit, we can give a trial extubation for the patient when the patient is fully conscious and oriented and awake.
Is there any role for regional techniques for this surgery?
Since it is lap colisor, you can try regional technique like tap lock is no longer recommended nowadays because it's not visceral pain is not addressed. So if it's severe pain is there, local infiltration and erector spinae block if needed can be given.
What about epidural, segmental epidural, combined spinal epidural?
With opioids alone can be with the fentanyl. But morphine cannot be given because it post-operative delayed respiratory depression can be a complication. So, if it is
there have been reports where they have done these cases under epidural in very sick COPD patients who are not suitable for general anesthesia. They have done what is called segmental epidural anesthesia. Okay? So you just block between T4 to L4, L2. That is more than enough for this surgery. And the shoulder pain can be managed with small doses of IV fentanyl or 5 milligrams of ketamine. They have found that it is quite successful in blocking the shoulder irritation pain because of the diaphragmatic irritation. That is the main concern. So that also has been accepted as one of the techniques in very severe COPD patients. Okay?
Okay.
Very good. Okay. Do you think any other points to be added?
I think she certain questions she didn't kind of understand what you were asking. I think she needs that kind of attention. Ammu, you're very interested in answering whatever you want to say, but you're kind of not listening to what sir is asking. Yeah. So I think that you need to. Yeah, that's right. Otherwise, you're fine.
Right. There is an old PPT which is there, which was shown during the last class. I will just quickly go through that and